Well, so Dr. Byrd, thank you so much for finding the time to talk to me, and congratulations on your new job.
Well, thank you very much, Paul. It's great to be here talking with you and to be in a new position with the opportunity to make great impact.
Oh, yeah. I mean, I just thinking out loud, and I haven't, this is, my memory could be a false memory, but I think UPMC is one of the largest cancer centers in the United States, like number 4 or 5, isn't it, by
It
number of
is.
patients?
It is. One of the things that really excited me is, when I was looking at this position, that it's the biggest system in Western Pennsylvania. It extends it extends through 4 states: Ohio, New York, and Maryland, and 3 countries: Ireland, Italy, and Croatia, and with approximately 80 sites focused on cancer. 2,000 employees, and that include the researchers, the physicians, and staff. So they care for 180,000 new patients a year. I know we treat 180,000 patients a year, and that was really exciting. And UPMC is you may know this, Paul, but it has a really unique structure in that UPMC and the University of Pittsburgh are joined at the hip. So you have that phenomenal clinical component with a partnership with the University of Pittsburgh that is ranked number 6 in NIH funding and really has just phenomenal basic and translational science and education of trainees. And so this is the Matrix Cancer director's job of dream job, because you get to bridge both of those and really also take a hub and spoke approach of cancer care, which I don't think I've ever shared this with you, but that probably the biggest attraction to coming here was the hub and spoke approach, because I grew up in a small town in Arkansas and called Augusta, and we lived in the country from there, and it was the poorest county in the 49th poorest state. Thank God for Mississippi, who's 50th. And my mom when she was 52 was diagnosed with a cancer of unknown primary, and we literally, for the 6 months of her cancer journey, had to drive 78 miles to Little Rock to get care. And when she would go in the hospital, she would have to go to a regional and then get transferred to Little Rock. And so from a personal standpoint, having to live the journey with her, and see how being treated far from home is so difficult on patients. The model that UPMC has of hub and spoke, of people giving the best care closest to home, and trying to minimize patients traveling, and using the physicians at the main center to aid the physicians in the network that are at satellites, at satellite sites, just was really attractive. And so I think that taking that to another level as well, of being able to take the research that we're doing, the education that's being done for cancer, and all the supportive care, and also getting that out as much as possible to where patients are getting, the research that we're doing is really something that's disseminatable, to the community, which is, something, we often forget when we're at universities, is, what can be done in a university often can't be done at somebody's, home, in a rural or, less populous area. So as I look at this job, though, it's being chair of, first of all, leading a division of hematology and growing that, and sort of doing almost every job except for deputy director and director of the cancer center at Ohio State, and then being a chair of medicine, which sort of gives you a unique set of skills that are different. Well, I wasn't looking for a job when Anne Marie, when the search committee chair called me about this position, it was like, this is going to be amazing, because it brings together all the great aspects of a dean's job, but that's focused on just cancer. And the idea of being able to lead research, say through this matrix organization and education, and partner with Beth Wild, who's the president of UPMC Oncology, and Stan Marks Dr. Stan Marks on the clinical stuff. Man, something really, really exciting.
Yeah. What about the hematologic malignancies focus? Is that going to be something you will be exploring more at UPMC?
Absolutely. I think UPMC has been really known for its immunology, its solid tumor oncology. Actually, the two of the 7 viruses that cause cancer were discovered at University of Pittsburgh, UPMC. Heme malignancy has been very strong clinically, and really one of the things that I hope to do, over the next 5 years is to build the strength around that, and disseminate again a lot of the therapies that we're doing to the network. And our team at where I was at before was very involved with developing the Bruton's tyrosine kinase inhibitors, ibrutinib and acalabrutinib, which really impacts CLL care. One of the things that after we got through the clinical trials that came through is about 50, and we saw about a 10% stoppage rate in the trials. And when that got out to the community, real world data showed that about 50% of people were stopping the medicine. So really taking heme malignancy and again showing that what we're doing in the hub can extend to the spoke and really be applicable to all patients. And if it's not coming up with strategies, and I would say from our work with ibrutinib and acalabrutinib, one of the things I learned is that probably people discontinuing therapy, that could have been abrogated had we had better education in the community. And so I'm really, again, this idea of taking research in heme malignancy and really what cutting edge research and showing we can apply it in the community is something that really excites me about this position.
How would you do this? How do you get all docs to follow the same pathways, or what would it be? Would it be pathways? I guess I just spoke a little bit too fast here, because it could be other approaches. How do you do it? How would you do it?
Well, I think it becomes one. So everybody, and everybody I've met. And there are very few physicians that don't want to give the best care to their patients, and in a very empathetic way. And I think often it falls upon those of us who are doing trials and have the hands-on experience early on with therapies, to really educate and educate. And often, and I think I can't remember, it was in the Cancer Letter. There was somebody that looked at all of the abstracts at ASCO and ASH, and like 75% of them had the therapy was well tolerated. Well, 75% of all the drugs we've tested in cancer, I will say, have not been well tolerated. They've been acceptably tolerated, and some people don't tolerate them. And so getting the education out, and also realizing there has to be communication back, and again, really, so building the culture where say the folks in the community, whether it's somebody in Erie, is comfortable calling and talking to somebody, say in Pittsburgh, about an adverse event that's happening, and getting input is important. And I think that's how you do it. You have a team that's comfortable calling and asking, and you have two-way education about particular therapies as they're coming, as they're moving from say a very close say hub at the university to the community.
So is it more of a educational process, or is it guidelines, or is it pathways? How do you do it?
I think it's a combination of all those things.
Okay. And you have them probably, right? Or education you'll build that. If you don't have it, then you probably have it.
Right. No, and that exists. That exists, but I think we can do better. And that's the fun thing. And as I thought of anytime you move to a new position, you want to really have a fundamental a fundamental vision of what you're going to accomplish. And really one of the things that if say we're looking 5 years from now, I'd really like to be able to say that at the UPMC Hillman, 5 years from now, every single patient that we're treating in 5 years is going to get better care in some way, whether it's say dealing with adverse events for therapy, we're doing better survivorship, we have better outcomes in terms of higher cure, but every patient, and we're going to hit that mark. And part of it is education, part of that is bringing new things forward, and part of it is focusing on things like geriatric oncology, exercise therapy, integrative medicine, and survivorship, that they're real important in our specialty now, because we're so blessed to have patients living, whereas in the past they were dying from cancer, and so addressing things that happen as a consequence of survivorship, and also being sure that we're giving the appropriate therapy to the appropriate patient. And geriatric oncology and things like this often don't extend to the community, and again, that's something, even for diseases that we're doing very well with, we can impact the community better by employing.
Mm-hmm. Mm-hmm. But what about them? I guess one of the reasons people don't do it is you can't make money on it.
That's exactly the point. And again, one of the exciting things about UPMC and looking at the UPMC Hillman is that UPMC has 4 arms, and one of them is insure it, and they insure over 4 million people. And if so that the UPMC organization itself, through the individuals they insure, have the justification really to do things that are going to actually lower the cost of care over time while improving outcome. And some of these things, though, as you said, Paul, like geriatric oncology, say survivorship, integrative medicine, when you look at the whole picture, there are ways to make money, and that's one of the things that I saw work really, really well to support things like this in the community at a place that I was at before Ohio State with Pelotonia, was events that can bring the community in with people recognizing some, as you said, some things that really improve cancer care are not are not reimbursed, and through events, and we have an event in Pittsburgh that's getting started called I'm blanking on Rush to Crush Cancer. It's a bike ride, and it's in its fourth year, and things like that where you get people out to ride, that fundraise, they get good exercise, they lose weight, they're at less risk of cancer from obesity related cancers or overweight related cancers, and it raises money, that just like the Pelotonia event at the James, that entirely comes back to fund cancer research or things that benefit the community. And this is something really I'm looking forward to, to growing, both from the health standpoint, because I saw, where I was at before with Pelotonia, people that would get out and bike ride, that you look at them and you say they have no business being on a bike. say in the sense that they were so they had every reason to be on the bike, but they didn't look like your typical biker because they were overweight. And by the time Pelotonia came, by the time the ride came, they had lost weight, they were healthy, and that builds camaraderie, and also again, it brings the community into the journey to fund things in cancer care that maybe are not reimbursed well, but where you can provide them.
Mm-hmm. Well, of course, being a health system, and you could and an insurer, you could have some savings from
absolutely
wellness of some sort. Yeah, but it's a very interesting. But that sounds like it's a work in progress for you, figuring out how to get the money.
Well, it's Rush to Crush Cancer is brand new, but it's one of the things I'm really excited about, because I saw Mike Caligiuri working with the community, and we were all part of this, but Mike Caligiuri, who you remember Mike, I'm sure,
very well.
really brought the team together and built Pelotonia, which again, it funds research, which is important, and education and for fellows and students doing research. But it also did some really big, impactful things for the community. Say like the colon cancer screening initiative, and really building upon what Mike did. My hope is really to use some of these funds to direct toward prevention. As I said, geriatric oncology and exercise, initiatives, that are really showing to benefit cancer patients. But again, patients but it's not reimbursed. But it ultimately serves the greater purpose of improving the lives of patients with cancer or preventing them, which is even better.
Mm-hmm. Yep. You're at the point where you're drinking out of a fire hose. When is the CCSG due?
September 2026.
Okay, so you've got time, right?
And I've been blessed, Paul, that with Dr. Ferris, so there were 4 directors here in 45 years. Wow, so those are big shoes to fall in. But Dr. Ferris has been gone for a year, but there was an incredible interim, leader appointed, Catherine Schmitz, Dr. Catherine Schmitz, and she really pulled things together, and I feel like I'm walking into really a position that that she just decided to go on a cruise for a year, and is handing me a cancer center, the research and education part of the cancer center that's ready to go toward the competing renewal. Now, nobody knows. The review process and such has changed a lot, and we're still waiting for say what they're going to want, how they're going to want the application formatted this year. I'm just the team that's here has just really left things in a way that really we can just move forward, and we have to of course renew that grant. That's obviously important, but we have to focus on the principles of why you get the grant. Because the grant is a symbol that you're really providing a comprehensive cancer care and research and education and really hitting the needs of the community, and I believe we're in a good place for that with the work of Dr. Schmitz.
What about recruitment? Would that be whom do you need to recruit now? What's the focus there?
Yeah. So that's right now. The areas where we've had a few departures. Probably the key recruits. Say Dr. Schmitz is going to be assuming a deputy director role. Say with me coming in as director, and she's been the associate director for population science, and so we will recruit that position, and that research is underway. And then Monica, that's been left to go to VCU, and so we're recruiting an associate director for COE. And right now I've appointed an associate director for clinical research, Dan Zandberg, so those two associate director recruits are in place. I was really lucky to arrive and have a really solid HEMOC division director, Dr. Chuck Geyer, and he's going to be our permanent division director, and he brings a lot of experience and both from NSABP and all of his breast cancer clinical trial work. So I think areas scientifically that we'll be looking to recruit, say clinical trialists, say in several solid tumor areas, and the heme malignancy group we will be looking to grow with both physician scientists and clinical trialists, and as well our population science, particularly focusing on geriatrics and epidemiology and viral oncology. Those are sort of the areas that we're looking to recruit in the next couple of years.
To build that up, how many people do you think altogether?
Well, I think it's a moving target, and we're in exciting times. But we're, and I think as we move forward, while we're being cautious, and deliberate in who we're recruiting, we really see this as say that the times that we're in, it's the opportunity to really build a great team. So I think we will, there's not an absolute number, but it's filling in, both the backups who are the next and up and coming leaders in our programs, and growing areas that we really want to focus on in the future. And again, that's going to be obviously drug development in both solid and heme malignancies, and as it relates to clinical and in surgical oncology, the University of Pittsburgh and UPMC has one of the top. We train people from around the country on robotic surgery and in cancer, and that's going to really be. We're going to really try to focus on supporting the translational and basic science that goes into when I say basic science and engineering and other support for that group.
Mm-hmm. When Bob Ferris took his job some years ago, I asked him, in a similar interview, what's your focus? And he said immunotherapy. So if I were to ask you, what is your focus? Is there a single area, or is it several things? Is it doing everything you're doing plus something, or is it just doing everything you're doing, which is no shame there?
Yeah, you're asking for the center as a whole. You're asking for the center as a whole. What our focuses are going to be.
Yeah. Whether there's anything new that you would like to develop that's not there. Like, I mean, you're a CLL, AML researcher. And
So I would say the Hillman is best known for its immunology and immunotherapy and translating that. And so you really grow your best team by supporting what you're best in and then growing out other areas. And so I would say new areas that I would really like to see develop over the next 5 to 10 years, for sure. Our heme malignancy clinical program is exceptional. Is building that out to where we have destination programs where people are coming from around the country to get care in specific tumor types, and CLL is an obvious, but other blood cancer, multiple myeloma, myelodysplasia, and then similarly in solid tumors, building destination disease areas, which is something that Hillman has. The UPMC Hillman is really focused on. The region. People come nationally, but for select things, but the focus has been mainly on regional care. And then I highlighted earlier, drug development and cellular therapy is something with the School of Pharmacy that I think is so important as we're moving into an era where cytotoxic therapy is almost becoming a bad thing. And I truly believe it's with targeted therapy and the immune system that we're going to cure most cancers. And so building the infrastructure to translate those areas, and then finally, it's geriatric oncology, and really with the hub and spoke, survivorship and AYA linking, because there's a really good children's hospital here linking, that I believe is ranked 6th in NIH funding, ranking is bringing the Hillman pediatric program a little closer to the adult program through an AYA program. If we're doing this interview 7 to 10 years from now, and we all of those are in place and are better, then I'll be happy.
Mm-hmm. That's a massive program. I guess we
like to think big and bold, as I say, and we can think big and bold, and there some of those things we may not be successful, but I think one of the things when you have a great team, you push the team to do as much as they can, and every once in a while you say everything comes back to football in Pennsylvania and Ohio. Every once in a while you win a national championship, or Super Bowl.
I love that one of your buildings, the Crane building. That's quite amazing. It's just seeing that. It's just like nothing else out there. But yeah, what about money beyond the government? Is there a source of income you can think of? Is there any way of kind of getting beyond where money from an NIH?
Gosh, say if Paul, I would question if I gave you $1 to ask me that question, or offered to buy you a cup of coffee to ask that question. So that was one of the things that really pulled me here. is, say UPMC has an organization. It has 4 divisions, but one of its divisions is enterprises, and enterprises invest in different technologies, but a lot of technologies coming out of Pittsburgh and laboratories in the Hillman. There are a number of things that have been commercialized, from scientific discoveries, and because I believe that the entrepreneur of bringing, of taking discoveries and commercializing them, for sure has the opportunity to bring back revenue that can fund further research, and that's an area that I've really enjoyed doing with different models at both the Ohio State and the University of Cincinnati, and that I look forward to teaching people how to do that. While maintaining, in some cases you can maintain, your separation from conflict of interest, but in a lot of cases you can't. But there's nothing to be ashamed about that, because in addition, because that's if you're successful in doing that, there's really no discovery that's not commercialized, that ultimately gets disseminated. You have to, if you're particularly in drug development or device development, if you don't commercialize it, it's not going to disseminate to help the body of people that you want it to. So enterprises is a great internal facility to do that, and also the population. When you think of, if you're treating 180,000 people with cancer a year, and you can really bring trials to the community with that. That's what companies want now. They want decentralized, research done with therapies. In the U.S., we saw a secondary appointment of glofitamab get turned down because we didn't have enough Americans on the trial that was done with that. And so we're really taking this network, getting this and really pushing research into it. I think it brings an opportunity to bring revenue back. Again, that you could reinvest into new research. The last thing really, and philanthropy is so important. Grateful patients and people that want to invest. And we're in such a different time than and I think you may be able to say when 15, 20 years ago, or even 10 years ago, if you had $1 million and you had a relative diagnosed with cancer, and you put that $1 million, you said, well, I want to give this $1 million to help my family member to move the therapy forward for their cancer. There's no way it would happen in the time period that you could benefit that patient. Well, now we're in a different time. It's realistic that if somebody that you want to invest in the therapy, even for an individual with cancer, that you could see that that therapy move forward in the time period that it could affect that person. And so we're in a special time, and so really being able to bridge philanthropic investment to hit some of these goals is also something that with the team we really hope to do.
Mm-hmm. Is your dowry strong? Is there a lot? Is the recruitment package strong? And also, I guess I'm just wondering. I think we're in different times.
I'm not sorry. So we're in different times that, I think, say 10 years ago, 15 years ago, people would move and, or you get you get $100 million package or $50 million package. And one of the things that in my last two positions, I'm much more have advocated with those that I was negotiating with to build greatness. Is let's rather than because in business you don't go to a job even if you're and get a big chunk of money that just sort of sits there. Say you get a chunk of money, and if you're successful, you get more. And that's how I've approached my leadership. That's how I've approached every position I've been in. What I've been told, is that what I've been told is the UPMC, Hillman and the UPMC organization invest in the future and invest in impactful things, in a business model, and so there's been an adequate investment to hit our goals and believe that we're going to be able to accelerate those. And the same thing on the University of Pittsburgh side, and through the collaboration that exists.
Mm-hmm, mm-hmm. So you think you're all right on the money? There are many other things that keep me up at night, but that's not one of them. Okay, well, that's a good thing. So what does, since you've brought up the subject, what worries you the most now?
All right, so first of all, probably say we are in uncertain times, and I gave you my background of where I grew up. I was in the Army for 10 years. A first generation college grad, both sides of the family. So money has always been a thing, and really pursuing excellence and being best. And and I say this, as an American, that the NIH and the NSF really was what changed us from being a country that predominantly produced to being an innovator, and distinguish our country, through technology, new findings, from just being a producer, a manufacturer. And so I'm really nervous that that's something that has really raised our country to another level. The NIH, the NSF, and our other investments into core basic translational and clinical science is being challenged right now, and because when we look at the dollars that come from that are invested into the NIH, it's clearly has great ROI, and it's distinguished our company. It's made us, it's put us at number one. We want to stay there, and so that's obviously something I very closely follow, and I was really happy that Susan Collins and the bipartisan Senate and decision to maintain the NIH budget, not do multi-year funding, not recommend multi-year funding, and because hopefully that keeps me awake at night, because that's a core part of what's made our country great and distinguished us from other countries that have been that are second to us in research. I think the other thing that keeps me awake at night is just really being sure that in taking this new position that that both we're providing the level of care, that empathetic care far from here. But while giving every individual that's in our network access to, the best research and working to take down barriers to that. And for all the people that are on my team, and again, it's a big team. It's 2,000. It's 2,000 people that they're all growing, and and are happy in what they're doing. Because if they're happy in what they're doing, then we're going to be more successful and more impactful.
Yeah, you also have a unique system, which is more of a hybrid than a lot of other cancer centers. Community piece of it, and the academic piece of it, and
I'm going to correct because community. So I'm going to say network rather than community because no. But it's a network, and I say that because often community often gets disassociated with research and other things, and a lot of our network doctors are really active in research, and and it's just the further you get away from the university and say our university our sort of dual university and UPMC physician providers probably they're not doing as sophisticated research because you can't do a phase 1 study say in a small office, but it's unique in other places I've been where the community doctors often are totally disengaged with those things. Research is not something that's done, and again, I think that's a part that really excites me. Not all of our sites are doing are doing research yet, but that's a goal that we will hopefully we'll get them to that as we're doing this interview 5 to 7 or 10 years from now.
Yeah, but in terms of having the elbow room for what you need to do you feel like the for-profit piece of the practice of the whole sort of enterprise is going to allow you to do everything you want to do?
Yeah, well, the whole enterprise is a not-for-profit, and I think how people are compensated, really, as to say, matches where they are at, and the amount of clinical time that they're doing. But but the entire UPMC organization is a not-for-profit. Now we can get into say all organizations, whether they're not-for-profit or for-profit, have to pay for themselves. But the nice thing about not-for-profits is that and I don't have the exact number, but I know I believe UPMC invests like $500 million a year back into research. The University of Pittsburgh, through supporting things that are going to make things better in the future. And a for-profit organization, is sending those dollars back often to their shareholders. So it's different.
Mm-hmm. Well, I guess maybe I'm.
So one of the most attractive things about this position was, and if you talk to anybody, everybody in an organization has an important purpose, and network doctors, and Stan, I think of Stan as one of the premier. He's the best doctor, heme malignancy physicians, and I'll just use Stan as an example. But say the network doctors generally, do more clinical work on the average, than the academic, university-based practice, and the market value for those two, are different. And I think there's a really, really good balance, and UPMC has really worked hard to be sure that that everybody is being compensated, and I think this is what you're getting at, appropriately for the market value of what they're doing for their clinical work, and everybody everybody in, whether they're in the network or in the faculty practice, are an important part of the Hillman team. They just do different, they do different things to the end, the end goal. I found one of the attractive parts of coming here is every place I've been before, and when I go and consult and such, and somebody says, and you're talking to physicians on the academic side that want to that want to do research, and very few of them want to do more than 50% clinical time. And most people that work in community, generally want to be practicing and spending 80-90% of their time seeing patients. And so you have that balance where both can do what they're good at, and for the better of the whole organization. I'm really comfortable with the fairness and the alignment, and although for sure you can always be aligned. You can always be aligned better and have teams working better, and that's when you stop working to get better, then it's time to stop. It's time to stop working.
Mm-hmm. Yeah, but is your I guess what I'm asking is whether you have the power to bring in new people, to recruit, to do all of these things, whether you have sufficient autonomy from those other folks.
Oh yeah, well we're one team. So yeah, Stan. On the clinical side, Stan, Beth Wild, and myself are equal partners in the clinical. And again, and really one of the attractive things about this position. One of the attractive things about this position is it's such a big network. You have to have somebody that's really strong clinically and administratively. And Stan for sure is that, and each of us contribute equally to making decisions as it relates to the clinical path that we path that we do. I'm blessed that Stan handles the day-to-day operations of the network, but we're equal partners.
Is it me?
In the clinical endeavor, and that's I think when you can have trust between leaders, and everybody does their part to their fullest potential, that's when again you have teams that impact things the most. And I learned this, Paul, in my last position at as department chair, and I'll divulge, and people might say, well, John, why don't you want to be in charge of everything or versus sharing things? And I ran the Department of Medicine chairs to divert a little bit. Department of Medicine chairs, it's too big a job for one person to do, I sort of bucked the system at Cincinnati a little bit and pushed them, and had a great executive vice chair, Dr. Nita Zali, who did all the clinical operations for the department. Everybody said, well, shouldn't you be doing that to the chair? And in the end, that dual leadership, worked great. I would say that's a model as organizations get bigger, for things to work best sometimes, and particularly complex organizations like ours.
Yeah, this is a very complicated place, of course. But yeah, no, that's fantastic. Is there anything I forgot to ask? Anything?
I want to just take a moment to thank you and yours and the cancer letter, because you and your team serve such an important role to our community and bringing things forward in a very objective way to say to everybody that reads and say throughout the cancer community, and I want to say thank you. I want to say thank you, and really also for giving the opportunity to talk about the UPMC Hillman, and to hear where we're going, and taking the time to spend with me today.
Well, thank you so much. It really means a lot to hear it. And it's wonderful it's very important for everyone to know where UPMC is, what's happening, and it's wonderful. And thank you, and congratulations on the job.
I think the other last thing that I will say is, other than interviewing with, I mentioned three people, Stan Marks and Beth Wild and Anne Marie, Anne Marie Lennon, who's the chair of medicine, who were really instrumental. The CEO, Leslie Davis, was so warm when I interviewed with her, and Anantha Shaker, the dean, and the senior provost for the University of Pittsburgh, who, instance, I got an accolade from her after accepting the position from I saw a patient 2 weeks ago, and she says, "You're going to be working with Dr. Shaker." This was somebody from Indiana that had worked with him. So, I think the leadership above you is really important. And I just, you asked if there's anything else. I just really want to thank them for giving me the opportunity to be in this position and hopefully to hit the goals. So, thank you, Paul.